Thank you so much for the invitation to be here today. I'm looking forward to sharing some of the work that we recently completed, focused on unmet mental health needs during the COVID pandemic in the Maritime provinces. So my name is Dr. Sandra McGallis. I'm a research associate affiliated with DataNB, but DataNB is affiliated with the Maritime Spore Support Unit, or MSSU. And this work was supported through MSSU and represents an interprovincial project that we conducted in collaboration with folks in Nova Scotia and in Prince Edward Island. So the folks that, sorry, I'm just going to try to clear up my screen here. The folks that we collaborated with were Dr. Amy Grant in Nova Scotia, myself here, and these are older slides, so we still have NBIRDT, but should be now DataNB. So the team consisted of 3 researchers from the 3 provinces, but also included a group of patient partners, patient public partners, that were also representing the lived experience of Maritimers with mental health conditions during the COVID pandemic. In addition to our core team, we also had a number of research staff who helped to support the work, as well as a broader group of research collaborators. So about this project and why we engaged in this project. So what we were seeing in the literature at the time was that previous studies during COVID were demonstrating that the pandemic was exacerbating gaps in mental health care systems. And what we were observing was also that mental health needs were increasing and that access to those needs were decreasing. And through discussions with our patient public partners, we learned that there was quite an increased representation of unmet needs that folks were experiencing. And so we thought that this might be an important area to focus on for our work. So we undertook a follow-up study using Mental Health Research Canada survey data to investigate unmet mental health needs in the Maritimes. And so what we define as an unmet mental health need is when a person has a mental health need, but that need is not being adequately treated. So the research questions for this work were 4. The first was really to understand how common these unmet mental health needs were in the Maritime provinces and how that compared to before the pandemic. We're also interested in understanding who was most impacted, and we focused on socioeconomic factors to understand how they related to the level of unmet mental health need. And then we were interested in understanding among those with unmet mental health needs, what were the mental health characteristics and what were the impacts from COVID on these folks? And we looked at them across these across 3 groups. So just to give you a sense at the methods, this was really driven through patient engagement. And so we co-developed this work right from the outset. We didn't have a sense of exactly what we would focus on, and that was developed through discussion with the patient and public partners. This was a secondary need analysis of data that was being collected across the country, but we focused on data that was collected in our respective provinces. This was done through an oversampling at a specific time point as these surveys were being conducted repeatedly over the pandemic. So Nova Scotia and PI participated in an upsampling in poll 10, whereas New Brunswick participated in upsampling in poll 9. So this allowed us to get a sense as to what is the experience across these provinces during this period of time. With sufficient sample sizes, because when they're sampling across the country, it wasn't enough to do an analysis at a provincial level. We weighted the data that we received using the 2016 census just to be able to better represent the population characteristics of the provinces, because we were using self-report survey data. And our analyses were quite basic and focused on descriptive and bivariate analysis. So getting into the results, we found that unmet mental health needs were quite high during the pandemic and remained so, and actually elevated in some cases. So overall, we found that about 25% of Maritimers reported an unmet mental health need. And so we split this into 3 different groups. So there was unsupported, unsatisfied, and unreported. So the largest group was unsupported. So these are people who said they had a mental health need, but they didn't access support. And we did have also data to understand why they didn't access support, and I'll get that to the next slide. There was the unsatisfied group. So this was 6% of the 25%. And so sick, unsatisfied means they were receiving care, but they were not satisfied with that care. So it wasn't meeting their need. And then interestingly, we found this group, which we called unreported. So based on some standardized, validated scales for identifying mental health symptoms of anxiety and depression, these people didn't say that they had a mental health need, but based on the symptomology, they did have probable anxiety and depression. And so overall, we found that about a quarter of the population had this unmet mental health need during the pandemic. And so now digging into each of these specific groups. So we found that roughly a third of the group was that had a mental health need were unsupported. And this was almost doubled or more than doubled since pre-pandemic, 16% compared to 35%. So quite a large proportion of unmet need was focused on this unsupported group. Well, who was unsupported or who was more likely to be unsupported? Well, we found that women were more likely than men to be unsupported. So 46% of women reported being unsupported as compared to only 25% of men. People who lived alone were more likely to be unsupported. So 45% of them reported being unsupported, and they were more likely than folks who lived with roommates, for example. So perhaps pointing at some aspects of social isolation associated with the pandemic. And in addition, folks who were living rurally were more likely to be report being unsupported than those in urban areas. So what was the reason for not seeking that support if you needed it? Well, the main reason that we found was really limited access. So the barrier to accessing care. And this was different than pre-pandemic, as you can see in the table. So the most common reason, 34%, was limited access. And pre-pandemic, it wasn't much of a concern. Ability to pay, the cost was a persistent and common barrier across. Very common folks prefer to manage their mental health symptoms on their own, but this did decrease during the pandemic. So people seem to be more interested in seeking support for the symptoms that they were experiencing. Now moving on to unsatisfied groups. So again, these are folks who were receiving care, but they weren't satisfied with the level of care they were receiving. And so we found that this was about 26% of people who were receiving care were not satisfied. And again, this represents 6% of all Maritimers. And this was very similar to what we found pre-pandemic, which was 28%. So who's more likely to be unsatisfied? We found people who are self-employed as compared to those who are working part-time or full-time to be more likely to be unsatisfied. Also those without medical insurance. So 37% of those were identified to be unsatisfied. We looked at simple analyses, as I mentioned. So it may be that people who are self-employed are more likely to be without medical insurance. And so these two things may be confounding one another. So now the third group, as I mentioned, was this interesting group of folks who had symptoms but didn't report that they had a need. So we found about a third of people who had probable depression based on symptomology did not report that they had a need. And then again, this represents 7% of the overall population. We can't compare this to a pre-pandemic period because these questionnaires are assessing more recent symptomology. And so you can't really ask someone about how they felt before the pandemic. It's just not comparable in the same way. So who is more likely to be unreported? So interestingly, folks who who are living only with a spouse or a partner had a higher report. 41% reported had symptoms but didn't report a need, and older age groups. So the middle age group was the group that had the lowest percentage of being unreported, but older adults. So this is interesting in trying to understand what the impacts of COVID may create environments that may emulate some of these symptoms that are overlapping. But we don't know for sure if those folks had any actual anxiety or depression just based on a screener, which would then, of course, require continued follow-up. So what did this look like in shifts in mental health access needs, mental health needs, access, and satisfaction? So a large proportion of the unsupported group also needed support prior to the pandemic, but more than half of those access care. So this is an interesting trying to understand or hypothesize what might be happening during the pandemic. Why are they not seeking the same supports? And further work might be able to look into that in this in these data as well, but we didn't do that here. Many of the unsatisfied group also needed support during the pandemic, and most of those who received it, they were satisfied with the supports they received. So there was certainly a shift in satisfaction or in the group that was satisfied or that wasn't satisfied during the pandemic. And then a roughly half of this unreported group actually recognized they had a need before the pandemic, with most of those who did recognize having a need before the pandemic actually accessing support. So it's just interesting to understand the experiences of folks in this time period. We also looked at the mental health characteristics of the folks in each of the groups. And so this is based on mental health screeners for probable depression and symptoms of anxiety. And what we found was actually that the unsatisfied and the unreported groups were more likely to have depression symptoms. And this was particularly interested for that unreported group. So that unreported group was more likely to report symptoms of depression rather than symptoms of anxiety. So you had to have one of those to make it into the group, into the unreported group, and they were more likely to make it in if they had depression symptoms. These are validated scales. I didn't mention the specific scales, but the PHQ, the Patient Health Questionnaire, is the one that's used for the depression, and the GAD, the General Anxiety. I don't know what the D stands for, disorder maybe. That's a validated anxiety scale. So, how did the pandemic impact the folks in this group? So, this is a really busy slide. I just want to kind of orient you. We have our three different groups, and then the yellow are just the folks who didn't fit into any one of those groups. So, what you can see is that the yellow is just the lowest bar. So, the impacts of COVID were more substantial among folks who we identified as having an unmental health need. The greatest impact seemed to be amongst the folks who were unsatisfied with the care they were receiving, which is interesting. But also the folks who were not reported seemed to have higher impacts of COVID on their experiences, on their mental health experiences, which may also relate to the fact that they're reporting symptomatology associated with these conditions. Sort of wrap all this up to provide some implications, evidence to support sort of a multi-pronged policy approach. So what we found was that 1 in 4 people in the Maritimes had an unmet mental health need. There was 3 types of mental health needs that we defined. 12% were unsupported, 6 were unsatisfied, and 7 were unreported. The prevalence of moderate to severe depression symptoms differed between the mental health groups. The most common reasons for not accessing care during the pandemic were really limited access, affordability, and the preference to manage oneself. But the preference to manage oneself drops quite a bit as compared to pre-pandemic levels, whereas access to care substantially increased. The differences in the types of unmet needs and the reasons for not accessing care indicate that really a multi-pronged policy approaches are needed to really get patients the right care at the right time. Um, Continuing on, thinking about how this might help inform planning and public health emergency response. So we did find that specific socioeconomic characteristics are associated with particular unmet mental health needs and severe depression and anxiety symptoms across groups. We also noted that there was a shift in mental health needs before and during the pandemic. So, more than half of that unsupported group did access care prior to the pandemic. So, understanding that more would be really interesting. Also, we found that more than half of the unrepresented group had recognized a need for support prior to the pandemic. So, that's also another area that will be really interesting to understand more about the experiences of those individuals. We also found that more of those who had unmet mental health need, particularly that unsatisfied group, reported more negative mental health impacts from pandemic related factors, so economics, or the fear of getting COVID or someone in your family getting COVID. And these groups were more vulnerable to the social or the economic stresses of the pandemic. So these findings all really aim to inform a targeted approach during public health emergencies. So these were specific to the pandemic, but we can think about the COVID-19 pandemic, but we think about these that might be generalizable to other emergencies such as climate-related events or hopefully not, but future pandemics as well. So of course, with all observational research, we have to acknowledge our limitations. So just to say that this is a cross-sectional study design and it's online self-report survey, but it is a robust method to get at information related to mental health and mental health need during the pandemic. But it can't capture the full experiences of participants, and we don't have a sense of the representation, but we did use weighting to try to adjust for that imbalance. The timing of the collection also may have impacted our results during the different time between when New Brunswick did their survey and when PI did their survey. There was the Omicron variant that came out and agricultural related issues happening in PI. So in New Brunswick's analysis, people may have been less on alert because COVID wasn't as imminent, whereas when the Omicron variant became much more common, we became more alerted on the need to, create restrictions, which may have impacted folks' mental health. We also have a small sample size. While we had about 1,200 participants in the study, we needed more to be able to do more sophisticated statistical analysis. As I mentioned, the folks who were self-employed and didn't have health insurance, like they may be the same folks. And so trying to understand and disentangle the effects of each of those would be really important for future work. But we decided to just take a first step and start to look at this data. So just some references. I wanted to say that this report is published and it is available on the MSSU website as well as infographics and summary documents and some other KT related products. And of course, to acknowledge and thank our funders that allow us to be able to do all this work. So CIHR in partnership with the SPORE, who is collaborating or partnering with the Government of New Brunswick, the Government of Nova Scotia, and the Government of PI, as well as Research NB. So with that, I would like to close off.